All right. Good evening, everyone, and welcome to tonight's talk. My name is Dr. Moreshi Mahlangu, also known as Dr. Mo, and I am the Chief Medical Officer of Clinix Health Group. And I will be taking you through tonight. I'd like to welcome to tonight is Dr. Lindokuhle Mahlase. He is a highly accomplished pediatrician and pediatric nephrologist with expertise in diagnosing and managing renal diseases in children. His clinical focus spans critical care nephrology, genetic kidney disorders, and advanced kidney replacement therapies. He holds an MBCHB from Medunsa 2007 and has completed fellowships in pediatric nephrology through the University of Wits, the CMSA, and the University of Toronto. He's currently finalizing his Master of Medicine in Peds and Child Health at UKZN, and he's committed to advancing pediatric nephrology through clinical practice and academic contributions. Since 2001, he has served as a pediatric nephrologist at Nelson Mandela Children's Hospital, where he leads care for complex renal conditions, including chronic kidney disease, acute kidney injury, and nephrotic syndrome. He has spearheaded groundbreaking initiatives such as the compassionate use, oh goodness, I might just butcher this, the compassionate use of nedrosin for primary hyperoxalaturia type 1 and recruitment for international gene therapy trials. Alongside his clinical work, Dr. Lindo mentors and teaches nephrology fellows and medical trainees, fostering the next generation of pediatric specialists. His research focuses on genetic variants in steroid-resistant nephrotic syndrome, pediatric kidney replacement therapies, and hypertension management in children. Today's topic will be pediatric hypertension, which I think the last time I had anything to do with this was in final year medical school, and I don't want to say how many years, decades ago I qualified. So I'd like to welcome tonight Dr. Lindo with his topic on pediatric hypertension. Please go right ahead, Doc. Thank you.
Thank you so much for the warm welcome, and thank you everyone who's attending. I have to declare that this is my first webinar, so please bear with me for all the glitches if there are any. I'm excited to be presenting this topic. Yeah, as most of the people have said, they don't know that we have pediatric hypertension. And unfortunately for our local contents, we still rely mostly on the American guidelines. Our guidelines are also extrapolated from the American guidelines. We're hoping that will improve this in future and have something that's tailor-made for our South African and Southern African population. So as I mentioned, that most of my presentation will be based on the sort of most recent guidelines when it comes to pediatric hypertension, which is from the American Association of Pediatrics from 2017, and what, because we all follow these guidelines internationally. So like everything in pediatrics, works with centers. If you're working with pediatric patients, you know that we're plotting everything from the weight, the height. And again, for pediatric hypertension as well, we define pediatric hypertension based on percentiles. So with the normal blood pressure being a blood pressure that's less than the 90th percentile for the height, age, and gender. Then elevated blood pressure is when it's more than the 90th percentile, but less than the 95th percentile. So this has been changed from the previous guidelines where this was defined as pre-hypertension, if you remember. So just the change in wording is more, to alert the doctors that this is the time for action. This is the time to intervene, because sort of pre-hypertension was reassuring that, you're not hypertensive as yet, and you relax and not do anything. Whereas if we change the wording to elevated blood pressure, then it helps with one realizing that this is the time call for action. So this is the part where mostly we advocate for lifestyle modification without any pharmacological therapy. Then we'll have stage 1 hypertension and stage 2, as we'll see as we go on presentation. Furthermore, as I had I just alluded that we have the abnormalities. Any blood pressure that would be more than the 95th percentile would be defined as an abnormal or stage 1 hypertension. This has to be on 3 separate occasions, and making sure that your patient is relaxed and you're using the right side cuff. Most of the patients that we get consulted for in-house for hypertension, you find that we're using a smaller cuff, and we just cure the hypertension by changing the size of the cuff. Then you have stage 2 hypertension, which is this is where we combine lifestyle modification combined with pharmacological therapy. This is not this does not include hypertensive emergencies. So hypertensive emergencies we'll discuss on the next or on the future webinars. So we'll just be talking about hypertension, but not hypertensive emergencies. Then again, when it comes to the best practice in terms of managing and measuring the blood pressure, we always advocate for that the patient has to be relaxed, more relaxed than me on my first webinar. And you have to make sure that they are not speaking, they are not fidgety. And we usually use different maneuvers in terms of that. We try some tablets and put on cartoons, but we have to be very aware of that. I had one of my patients that I was taking a blood pressure on, and he had a smartphone. And what he was watching, he had a smartphone and had his headphones on. And what he was watching was wrestling. So, that's anxiety-inducing type of content. So you try and make sure that if they are distracted by something that's not causing anxiety if we're using screens or something of that sort. We advocate for the use of the manual blood pressure cuffs. If you're thinking if the blood pressure is high on an oscillometry, we do advocate that you inflate your blood pressure to 20 to 30 millimeters of mercury above the disappearance of your radial pulse. I'm sure most people last did that in family medicine during medical school time. So when it comes to who should be measured, it's not who should have their blood pressure checked. It's not like, the adult population where almost every visit to a GP or a physician, you get blood pressure measurement as part of the routine things. So for pediatric patients, we say routinely, if the patient does not have any predisposing factors, and after 3 years, with every healthcare visit, be it's a well baby check, or they're coming for flu to the GP, or coming for immunization, after 3 years, we then advocate that we do a blood pressure measurement with every visit. Before 3 years, if you look at what I took from the American Association, the paper that I was referring to, that before 3 years, for the patients that are younger than 3 years, it has to be the patients that have risk factors to have hypertension. And the risk factors starts from prematurity. Any patients that was born for less than 32 weeks is at risk for future hypertension. So this is because it's hypothesized that the development of number of nephrons in each kidney is about 1 million, the actual number. And it takes to reach that number, it takes up to 34 weeks. Then the kidneys develop up until 2 years. So if you are born before between 34 or less than 32 weeks, you are born with less nephron mass in terms of each kidney. So that predisposes you to hypertension because you have a reduced GFR. And then the patients that are known to have congenital heart disease, the ones that have recurrent urinary tract infection, these ones would be the ones that would have scarring, or there is a family history of urological malformations. Those are the patients that, just briefly, that would require blood pressure monitoring before the age of 3 years. Then again, this is to emphasize again how to best measure the blood pressure. This cannot be overemphasized because most of the times the referrals that we'll get, it will be a technique related issue. And it helps in terms of once you've diagnosed the patient, it helps you in terms of monitoring. Okay. Then in terms of the equipment that we use, again, the cuff, we always advocate that the cuff has to be 2/3 of the arm span. If you look at the tape that's put on the screen, so you have to have your acromion to the olecranon, and at least the cuff has to be 2/3 of that to make sure that it's an appropriate size cuff. And in terms of the width, it has to be a cuff that at least covers 40% of the width. Then in terms of the circumference, you want a blood pressure cuff that covers 80% to 100% of the circumference. Then sorry. Then when it comes to primary and secondary blood pressure monitoring, blood pressure assessment, most pediatric hypertension is secondary hypertension. You have to look for a cause until proven otherwise. As mentioned in my bio, that I spent some time in the North American side where there is an increase in obesity now, and we're seeing more and more primary hypertension and even in the relatives. We still classify obesity for us because it's a correctable problem. We still want to classify it as a secondary cause, because if you correct obesity, then the blood pressure improves. But predominantly, we're starting to see more primary hypertension in the ages of more than 6 years. That was in the North American population. But by all intents and purposes, pediatric hypertension is secondary hypertension until proven otherwise. So we have to look for the secondary causes. We have to look for those coarctation of the aorta. We have to look for the renal causes. We have to look for the cardiac, endocrine, and neurological causes. So again, when it comes to assessment, we're going back to medical school. We always want proper history taking, that, if someone is referred to you or they're coming for immunization and you've measured their blood pressure on 3 separate occasions and you've confirmed and plotted them that they have hypertension, then we go back on history, perinatal history. Was mom ever sick? With, most importantly for hypertension in our cases, is congenital rubella syndrome. If mom had any infections during pregnancies, specifically rubella, because rubella causes renal artery stenosis, then it becomes important to us to establish if they had any rubella. We check on medication. Was this a smooth pregnancy that went to term? As I mentioned before, that prematurity predisposes to hypertension. And what was done, let's say the child was premature less than 32 weeks. Was there any sort of common, the people who do pediatrics will know that for our premature patients, in terms of ease of sampling and access, we use umbilical vein and umbilical artery catheters. So those ones can predispose to umbilical artery stenosis and umbilical vein thrombosis. So it's important to establish the perinatal and the birth history. Past medical history and surgical history is also important, because we could have our answer there. You could find that this is a patient that's known to endocrine for hyperthyroidism, or it's a patient that's known to nephrology who's on steroids, or someone who has had abdominal surgery before. And there was some, I had one patient who had a neuroblastoma that was removed, and there was an iatrogenic injury to the renal artery, and the artery healed by fibrosis, and there was just secondary renal artery stenosis. That's when it becomes important to explore all those past surgical history and past medical history. And if this is a cardiac patient, is this someone who had a PDA or someone who had coarctation of the aorta? So you have to explore all those things. So we go back to like the medical school kind of history taking. Then drug history, very important. There are lots of drugs that predisposing to hypertension, be it transient or sustained hypertension. As I mentioned, in my field, especially in nephrotic syndrome, we use a lot of steroids, and steroids predispose to hypertension. If you're dealing with a rheumatology patient, they might be using some of the biologics, like the CNIs, the calcineurin inhibitors, and those calcineurin inhibitors, we know that they predispose to hypertension. Some of the medications or drugs, they predispose to what we call transient hypertension, like caffeine. We know caffeine elevates your heart rate and you get transient hypertension based on the rate, but that's not sustained hypertension, and that's not usually associated with end organ damage unless it's consumed in excessive amounts. Then commonly now in pediatrics, you know, almost every other child is on Ritalin or methylphenidate, and we know methylphenidate causes hypertension, but I'll just briefly discuss that towards the end, because studies have shown that there is an increase in heart rate and an increase in blood pressure of about 2 to 5 millimeters of mercury, but there hasn't been studies that establish end organ damage or sustained hypertension with methylphenidate. So, which is quite reassuring, because it's we're seeing an increase in your ADHD. Then social history, this applies more to obesity-associated hypertension, where we're checking what is the child, what sports is the child engaging in, or any form of physical activity. Diet goes hand in hand. We know high salt diet that is high in fats, that predisposes to hypertension. And lastly, as I said, that I always put family history as the last, because we explore all the other possibilities before we label a child to have primary hypertension. And in terms of examination, of course, we go through our usual ABCs, make sure that it's not a hypertensive emergency, because that becomes, you know, an ICU management, which is not on the scope for today's discussion. Then we check things like syndromic versus non-syndromic child with hypertension. So the syndromes that we're looking here, those who are in pediatrics, you think of Williams syndrome, which presents with hypercalcemia, and you can also have renal artery stenosis. Turner syndrome, they would have short stature, webbed neck, and the most common cause of hypertension is coarctation of the aorta in the Turner syndrome, versus just a non-syndromic child. Then in terms of priority of which system to assess, that would be based on history, depending on who you are talking to. If you're talking to someone like who's a teenager, then you'll be thinking more of drug-related hypertension, more and more towards primary hypertension. Whereas if it's a 5-year-old, you're thinking more and more of renal-related, endocrine-related disorders and cardiac. Then the one part that I just want to emphasize on the ENT system, because this is sort of a newer thing that when we're in medical school, we were told that obstructive sleep apnea causes what we call pulmonary hypertension. But lately, studies have shown, I've had cases as well, of patient with obstructive sleep apnea with systemic hypertension. And the pathophysiology for this is the same as what causes pulmonary hypertension, those repeated episodes of hypoxia and hypercapnia, which eventually trigger your catecholamines, and there's increased heart rate and vasoconstriction, eventually leads to vascular remodeling and sustained hypertension. I've had cases, as I will show you when I'm going through cases where a patient had presented with obstructive sleep apnea and ended up with systemic hypertension. Neurological system, neurofibromatosis or a neurocutaneous lesion becomes important to us, because these ones are associated with renal artery stenosis, and we have to make sure that we exclude renal artery stenosis or any form of involvement of the kidney and the neuro condition. When it comes to abdominal examination, again, I'm in nephrology, so renal system becomes important, associated with endocrine, Then we look for any mass in the abdomen. As I said, made an example of the patient that I had with neuroblastoma, and it was excised, but we had injury to the renal artery and ended up with renal artery stenosis. Or even if it's still just a present mass that's compressing on the renal vessels, that predisposes to hypertension, like it predisposes to a functional renal artery stenosis. And importantly, the rheumatological disease as well, or vasculicities, they become important as well. It's important to look for anything, as we're taught, if, look at their fingers, look at their toes, if they have any vasculicities, look at their mouth for oral ulcers or the malar rash, because the vasculicities, they do predispose to hypertension. And again, in terms of workup, it depends on what is the suspected cause. That would be suspected based on your history and clinical examination. For an example, if you have a teenager, it's a girl, and you've explored that, it's someone who's on oral contraceptive, especially the estrogen containing, then you almost know your source of your hypertension. But in case of a patient that would be edematous, like my case is, then you look more from the cardiovascular to the renal system. That's when the chest X-ray, ECG, echo, your UNE, CMP, and urine dipsticks become very important. And importantly, we always emphasize on an ultrasound just to make sure that you don't have any congenital structural abnormalities of the kidneys and the urinary tract. And we do go as far as doing CT angiograms if we're suspecting that we might have what we call renovascular hypertension. This is when we do your renin and the aldosterone as well, if you're suspecting renal artery stenosis, and if you're suspecting things like endocrine disorders, pheochromocytoma, we do urine normetanephrines and metanephrines, but these ones we do them as a last resort if you have explored everything else and you can't find the cause. Then in terms of monitoring as well, once the patient is suspected or to have high blood pressure on your office measurement or screening, we do advocate for what we call ambulatory blood pressure monitoring on ABPM, or 24-hour home blood pressure monitoring. This is somewhat difficult for most places, as it's not available in most places, and it does require training in terms of the interpretation. So fortunately, I'm one of the people who's trained and who does monitor the patient, and this is what I'm bringing to the table again when it comes to joining the Clinix family. Then this is just an example of the patient, one of my patients that I had, that I did an ABPM on. And you'd notice this is a patient, I think this is a boy who had obstructive sleep apnea, and post removal of his T's and A's, he still remained hypertensive. But what was reassuring is this nocturnal dip. As you see that when you went to sleep this time, his blood pressure would dip. This nocturnal dip, if you read about the ABPM, you would know that even if you have uncontrolled hypertension, but if you still have nocturnal dip, it is associated with less involvement in terms of your end organ damage. Then this was one of my patients, again, that was referred for hypertension at base, and that was incidentally picked up asymptomatic, and this one proved to be what we call white coat hypertension. As you'd see, when the few hours after I connected the machine, he still had spikes that would go over the limit. But when he was at home, the blood pressure was smooth throughout, and went to sleep, the blood pressure was perfect. So this is somehow, we don't use it just to monitor the treatment, but we use it to exclude actually hypertension as well as part of white coat hypertension. I think, yeah, this was one of my CKD patient on dialysis who was not showing. If you compare this one to the first boy who had obstructive sleep apnea, you can see this one does not have good control in hypertension and lacks the nocturnal dip that we were seeing on all the previous two patients. So this one is where we also become equally aggressive with our management, because the absence of nocturnal dip is associated with end organ damage. So this is where we don't just advocate for lifestyle modification. These are the patients that for sure you would want to go for pharmacological therapy. And when it comes to the treatment, the initial therapy, depending on the stage of your hypertension, if you are still at the stage like what we used to call before pre-hypertension, or now that is referred to as elevated blood pressure, this is the right time to institute lifestyle modification, meaning good diet, exercise vigorously. And I'm not sure how many people have been successful with this. And I've personally had to change my resolutions for this year, because it's quite difficult without commitment and maybe having support from the whole family to just, lose weight and eat healthy. But if you have good support and commitment, we know that it does drop your blood pressure. So the other part, we talk about the DASH diet, which is a diet that is rich in vegetables, rich in fruits, and also just vigorous exercise for about 40 minutes, 3 to 5 times per day. And if obese, as I put on the picture, we do some motivational intervention as well, which is, we yell at them and we try and encourage the patients to lose weight. This is also very difficult in the pediatric population. I know in the adult population, we have like new pharmacological therapies like Ozempic that are really revolutionizing the weight loss in the adult population. But from our side, in terms of pediatrics, we still rely on physical activity. We still rely on your changing in terms of your diet. So low salt diet, physical activity, we still rely on that. Then when it comes to pharmacological therapy, so these are the patients like stage 2 and upwards, we advocate for pharmacological therapy, or if there is a secondary cause. So most people, this is where they will ask which agent to start. I always say, if it's a patient that's not an obvious nephritis, where you don't have like a history of hematuria, low urine output, and subsequent hypertension, then you have to start my go-to agent as an initial agent is a calcium channel blocker, and I'll explain why. But if it's a case of a nephritis, then your diuretics becomes your first line. So as cardiac patients who are volume overloaded and they are hypertensive as well, then it becomes obviously the diuretics become your first line. And I also like alpha blockers as well. Even though they are not readily available to everyone. And I will explain just briefly now why these are my sort of go-to agents as the starting, and then I can tailor make my treatment according once I've established the cause. So firstly, the ACE inhibitors. ACE inhibitors are good to us. I'm in nephrology. Most of my patients are proteinuric. So I like ACE inhibitors because they have the antiproteinuric property. But the issue is you have to have excluded bilateral renal artery stenosis, at least with an ultrasound, Doppler, or even with a CT angio. So it has this prerequisite that you have to have excluded renal artery stenosis, bilateral renal artery stenosis before you start medication. That's why when you're not sure, I do not advocate for an ACE inhibitor as the first line of therapy. Beta blockers like propranolol, they're good, especially in the smaller population, especially the neonates, because their heart rate is more, their hypertension is more rate dependent than contractility. But in the bigger population, like the bigger kids, the school-going kids, The issue with beta blockers is that it can exacerbate or even induce asthma. So, and you would want them to have competitiveness in terms of exercise tolerance and engaging in sport. So that's why the beta blocker, again, does not become my first line of therapy in school-going children. But in the younger population, like neonates, I do use beta blockers for the reasons that I'd mentioned. Mostly their blood pressure is rate dependent than contractility dependent. So reducing the rate does help with the control of their hypertension. But the things that we have to be cautious about again in neonates, when you're using a beta blocker, you have to monitor your sugars because it can induce hypoglycemia. You have to monitor your potassium because it can induce hyperkalemia. Again, beta blockers as a first line, I do not like them in bigger population because of the possibility of pheochromocytoma. If you have a pheochromocytoma, then you use a beta blocker as a first line, you block all the other catecholamine receptors, and all the catecholamines will just go to the alphas, and you can have an exacerbation of your hypertension, vasoconstrict, and actually have a patient that would crash was being put on an antihypertensive agent. So you can't use beta blocker in a pheochromocytoma, but not as a first line. You have to have alpha block first. So that's the reason why my first two go-to agents would be a calcium channel blocker if you're not sure what's going on, or an alpha blocker. Issue with the alpha blockers, they are not readily available in any other practice. It's mostly the practice like, that look after tertiary or quaternary places that would keep alpha blockers. Then again, when it comes to Ritalin, as I said, that the methylphenidate, because there's been a panic that methylphenidate does cause increase in heart rate and hypertension, but the data this is a study that I just want to reassure you with, that it has not shown to have long-term in terms of side effects, sustained or and organ affectation, as much as data both in pediatrics and adults has shown that it does raise the heart rate by 5 beats per minute, and the systolic blood pressure about 5 to 7, which is not really significant to cause any end organ damage unless you have other associated risk factors for hypertension. So same thing applies to adults as well, but it doesn't seem to cause any issues long term. But I mean, we will see as the current population grows. Then I just wanted to show you a few cases just based on what we've discussed, and we see how we manage these cases. So this was one of the cases that I had, which was a 6-year-old girl that was in congestive cardiac failure, and they had absent pulses and a dilated cardiomyopathy, and already they were suspecting coarctation of the aorta, and the patient came via cardiology, and they asked for assistance in terms of managing the blood pressure. Simple things, we took history. The patient had arterial hypertension, but what was strange, had fever as well that was associated with this, and there was weight loss and vomiting, and had intermittent claudication. So we're already suspecting a vascular cause, but this was not in keeping with what we're suspecting, as I was mentioning that, we initially was sent to us as coarctation of the aorta, but with the associated intermittent claudication, we started looking further. Then we checked the patient, and as I said, we always plot in nephrology or in pediatrics in general. So this is the app that I use to plot. It's my patient. Then she was 5 years, girl, and I plot according to her height, and you can see already that she was already plotting in the red. You can see because usually our charts are color coded like in the traffic lights, and you can see this patient was in trouble. Then we became aggressive as well because this is stage 2 hypertension. We did diuretics and initially, and started a calcium channel blocker. As I said, that they're my go-to agent when I'm not sure what I'm doing. And then investigated. I did inflammatory markers as well, including a PPD. Surprising enough, the PPD came back strongly positive. And the inflammatory markers as shown here, your ESR was elevated, but your aldosterone and your renin were within normal ranges. So as you can see, he had cardiomegaly and with an increased cardiothoracic ratio. We went on to do a CT angio on this patient. And interesting enough, we found that this patient had narrowing of the mid-aorta, mid-descending aorta. What was not in keeping with the coarctation of the aorta, you'd notice the inflammation around the inflammation, which was in keeping with the inflammatory markers that we've seen. And you can see this patient had developed collaterals that would be feeding the other parts of the body. Then this is just a depiction of the same thing in an AP view, where you see the inflammation around the narrowing of the aorta. And this is what we did, a digital subtraction angiogram. I'm not sure if this will play so that you can see just that's showing severe narrowing of that segment of the aorta. And so our diagnosis for this patient was Takayasu arteritis, and I won't just go to details in terms of the criteria, but it just shows the approach that we take. And our patient, there's different classification for Takayasu's. Ours was a type 3 because it involved the descending segment of the aorta. Then in terms of the medical treatment, we started steroids and methotrexate. You know, we're treating the hypertensive patient with steroids, but that's what helps with reduction of the inflammation. And the surgical intervention, we had to put a stent on the narrowed segment. Okay, case 2 is just a 14-year-old boy. I won't go into too much details, who was incidentally found to be hypertensive when he attended ophthalmology just because he had eye trauma, and he was found to have, this is meant to be 160 millimeters of mercury by the ophthalmologist, and then referred to a pediatrician, who further referred to us. When we did the secondary workup, most of it was negative, except for that the ECG and an echo had shown an LVH. Our urine dipsticks was negative and the urine catecholamines were negative. So this one, we went all the way out because we didn't know what was the cause. Then the renin and the aldosterone somehow were elevated. So that's when we did a CT angio as well, that you see a digital subtraction angiogram. This is where you see this patient had 2 renal arteries and the bottom one is narrowed. So this is a case of an accessory right renal artery with a renal stenosis on the second artery. So yeah, I hope I managed in this very brief time to convince you that pediatric hypertension is common if we look for it, and especially with the increasing rates of obesity. And again, that pediatric hypertension is secondary until proven otherwise, as you saw in the few cases that I've shared, that we had 2 cases of different renovascular hypertension. And in most cases, what we get consulted for as hypertension is usually a wrong size cuff. So we have to make sure that our patients are relaxed and we're using the right size cuff. And if unsure of which treatment to start, always go for a calcium channel blocker or an alpha blocker that do not have any prerequisites, like an ACE inhibitor or a beta blocker. For hypertensive crisis, that would be ICU management, and I'm hoping to present that in the next webinar. Thank you so much for your attention and your time in the evening. I'll be happy to take questions, but I cannot see that. Maybe you can help me with that.
Definitely. All right. So thank you very much for that, Doc. While I wait for any questions to come through, I wanted to find out from my side. You mentioned that prematurity is a risk factor for pediatric hypertension. Do you have any data in terms of the incidences of those who were born prematurely, how many then go on to develop hypertension?
Not off my head, but we are seeing more and more cases of what we refer to as the NICU graduates that have hypertension because of multiple factors other than the ones that I mentioned. I mentioned the less nephron endowment because of the development of the kidneys, but some of them is because of the chronic lung disease, which the same pathophysiology as is obstructive sleep apnea, where you have chronic hypoxia, hypoxia and hypercapnia. That further leads to release of your catecholamines and renovascular remodeling and hypertension. But in terms of the actual statistics and in our local statistics, I am not sure of, but we are seeing more and more of those.
Okay. And then you mentioned caffeine intake, right?
I survive on caffeine as well, but fortunately,
all
it's
do.
transient. It's transient. From at least the studies that are known, apart from all the other issues, it has not been shown to cause sustained hypertension. So I'm not sure. Yeah, let me give you a chance to. I'm already being defensive.
You
I'm being
already know where I'm
defensive.
going. Energy drinks. Our kids live off of energy drinks, right?
Yeah.
My son, I try to ban them. The school banned them during certain break times. It's a bit difficult. So that's where I was going with kids and energy drinks, especially because they have high caffeine content.
Yeah, no, definitely. We know that energy drinks have high caffeine content, but you know what's different from the energy drinks versus coffee? I'm not being defensive. It's the fact it's the sugar content as well. So the energy drinks have high sugar content as well. They have preservatives as well, which predisposes in a long term to obesity, which will predispose to secondary hypertension due to your high sugar content. But in terms of the caffeine, the bad part of the caffeine is the jitteriness, it's the tremors and the palpitations and all the other things. As much as we love it, we have to face the fact that there are some downside of it. And when it comes to energy drinks, I do discourage overconsumption because of same reason. You have high sugar content. More than caffeine, I'm more opposed to sugar that comes with the energy drinks. We do get patients that will have palpitations and electrolyte abnormalities due to overconsumption of energy drinks, especially when they're gaming and they just don't want to sleep and they want to have the game marathons. We've seen patients that will present with hypokalemia and arrhythmias. So, yeah.
Okay. So gaming marathons, right?
Yes, they do engage in gaming marathons. We've had like a few cases where they just want to game throughout the night during the school holidays, especially. Then they're popping in Red Bull after Red Bull. And they present with arrhythmias and electrolyte abnormalities. And, we were laughing at one case that it didn't give him wings. It made him flabby because of the hypokalemia, loss of muscle tone, So yeah, we do discourage overconsumption as much as, even just consumption to a minimum effect. Caffeine is not bad. Minimum of everything is good. But if there's overconsumption, my only gripe with the energy drinks is number one, the sugar contents, number two, the preservatives versus the coffee, which is just pure coffee.
Great. I'm going to quote you on that to my son.
Yeah.
So we've got a question from Pindile, which says, and this is actually quite interesting. It's a history question. I wonder if you'll be able to get this one. When was the first case of pediatric hypertension discovered in South Africa?
Ooh,
Yeah.
I'm not a historian. I'm more of a scientist, not a historian. I wouldn't know. I'll be honest with you. I wouldn't know.
All right. So we've got one from Patrick that says, what is your opinion on non-selective beta blockers for pediatric BP control?
As I did mention, that's a good question, Patrick. As I did mention that the non-selective, they have disadvantage, especially we want kids to be active, to have good exercise tolerance. So if you're going to have a non-selective beta blocker, that's going to disadvantage the child with all the bronchoconstriction, reduce exercise tolerance. Then it sort of defeats the purpose of what we advocate for, which is, we want kids to be active and not to be obese. So if the kids are disadvantaged by, side effect like bronchoconstriction and reduced exercise tolerance, so we try by all means. That's why I mentioned on my slides that I'm not a big fan, of using beta blockers as a go-to agent, especially in the school-going kids. I explore all the other agents, if maybe I'm struggling with the control, then I go to the selective beta blockers and the non-selective because of the same reason that I don't want them to be disadvantaged by exercise intolerance.
Okay. So we've got a question from Ellen that says, considering that these kids will have to start pharmacotherapy at an early age when diagnosed, what are the long-term side effects that they could suffer from?
Yeah, that's an interesting question again. Just today I had one of my patients who's on my favorite calcium channel blocker. I had to stop because she had gingival hyperplasia and she had worsening of the edema of the limbs. She's well controlled. She's a nephrotic syndrome who has hypertension as well. But the edema now is now coming from the calcium channel blocker, and she has gingival hyperplasia, and that cosmetically is not appealing. So there are different side effects according to different classes. We know Black population majority do not tolerate the ACE inhibitors very well. I've had patients who had chronic coughs. I've had a case of neurogenic angioedema. So it's short-term and long-term side effects. There's no innocent medication, and each side effect is dependent on class. And if it's diuretics, mostly we see electrolyte abnormalities and, acid-base abnormalities. So the side effects are really dependent they are dependent on the class of an antihypertensive agent that you are on.
So I think just a follow up to that, then it's maybe, I don't know if it's similar in adults, but if you start any antihypertensive in a young age, what is the likelihood then of eventually having to change the antihypertensives? Would you be able to say this patient can be on a calcium channel blocker well into their young adulthood if they started early, even with minimal side effects? Are we looking at adequate BP control with maybe one drug? Or what is the course that we're looking at? Would there have to be constant escalation, considering that they've started your antihypertensives at such a young age?
Yeah, so on my side, what I rely really on is the ambulatory blood pressure monitoring, as I've shown you. I use it to diagnose hypertension. I use it to monitor therapy, because some of the patient, if you do just an office blood pressure, you find that it's still elevated, even if it's a secondary hypertension, but you finding that there's an element of white coat hypertension added to it. So playing around with antihypertensives to me depends on, do I get side effects from this antihypertensive class, or do I have good control on an ABPM? I do not rely on an office. If I have on an office blood pressure monitor, if on an ABPM, I have good control on, let's say I'm on 3 agents, then I choose which agent is giving me benefits. Again, if there's a beta blocker amongst those agents, for me, the beta blocker is the first one to go, unless if I have like cardiac involvement where there's like LVH and, I'm dependent on the slow rate for the myocardium to perfuse, then I'll keep a selective beta blocker for those reasons. But usually for the school-going children, again, the first agent that I would want to drop on my side is a beta blocker. And, titrating going up or down depends really on what is the underlying cause. If my underlying cause is a nephrotic syndrome, again, I use ACE inhibitors because I get the antiproteinuric effect of the ACE inhibitors coupled with the antihypertensive effect. If, it's something else, I really, playing around with the antihypertensive agents for me depends on the age, what am I achieving, what are the side effects, and what is an APPM saying. So that's how I play around in terms of adding or removing the hypertensive agents.
All right. So we've got, okay, let's look at some of these questions here. Just bear with me, everyone. The questions are coming in. So our next question is from Monica. Monica says, what quality of life do such patients have generally? And would surgery be an option at one point? So I think Monica's asking a very general question. And I think for me, maybe let's just direct it a bit more. It's like maybe like your top two causes of pediatric hypertension. What is their quality of life looking? And do they need surgery in terms of some, like maybe your top two or top three causes?
So let's I'll talk about renovascular first. So renovascular are the two cases that I showed on the slide. Like this one, if you look with an accessory renal artery, this one we try and not do surgery as much as we can because the lower pole of the kidney, is dependent on perfusion from that artery. So we use mostly, pharmacological agents, and it's a lifelong commitment to pharmacological agent because there is a lifelong persistence of an accessory renal artery. So, we do get difficulties with teenagers and compliance. No teenager wants to be on medication. So that's when we depend on family, psychological support and everything. So quality of life on medication is not the best, but we try, okay? Then if you look at the previous case that I discussed, that's definitely there was no other way beyond just immunosuppressive agents. We had to put in a stent. We had to put in a stent to overcome this narrow stenosis. There was no way. The patient has claudication. I think the surgical intervention actually improved the quality of life of the kid because now she could walk, she could run, she could be happy, things that she couldn't achieve. I mean, I think those are just two examples of the renovascular cases where one is strictly pharmacological, where the other one, it was non-negotiable surgical. The other ones would be nephrotic syndrome would be the commonest one. And I really depend on how the nephrotic syndrome responds to my initial therapy. If I get steroid response, usually I wean off the steroids and, the hypertension follows suit and resolves. But I battle with the steroid resistance and I have to have an ACE inhibitor, and it's a sort of lifelong therapy until the patient goes to end-stage renal disease when the kidneys bomb out and they're no longer losing proteins. So it depends what is it that you want and you define as a good quality of life. Because if I have an ACE inhibitor on board and it's helping me with the control of hypertension and control of the protein, the patient stays away from hospital, stays away from being admitted. If they default, I mean, if you don't want a pill, then they get frequently admitted. So when it's difficult to define, quality of life, because sometimes, like putting them on medication and controlling their blood pressure lifelong and controlling their proteins lifelong, keeps them out of hospital. But, it's no one wants to take medication lifelong.
That's so true. I mean, even adults,
True.
just getting an adult to take medication lifelong
Yeah.
is an absolute nightmare. So we've got a very interesting question from Patrick that says, Patrick, you've got them coming today. Would you advocate for tonsillectomy as part of the control of high BP secondary to glomerulonephritis?
Secondary to glomerulonephritis?
Yes.
No. Okay, I would say no if it's strictly secondary to glomerulonephritis. I thought you would say secondary to obstructive sleep apnea. I was already nodding because we've seen improvement in terms of the quality of sleep. We've seen changes in an echo when it comes to obstructive sleep apnea. We've seen some improvements even in our APPM, but just secondary to glomerulonephritis, unless if the glomerulonephritis is secondary to what we call an IgA nephropathy, which is, we know the IgA nephropathy, the IgA is rich in places like the tonsils and the GI system. So those are the cases, the few cases where we advocate for tonsillectomy to control the glomerulonephritis, because we remove an IgA rich area. It's specific, it's a very specific form of glomerulonephritis. That's where we consider things like a tonsillectomy, but not just generally in any other form of glomerulonephritis where I would go on, and because then the pathophysiology and the driver of the nephritis is different. But in an IgA nephropathy, we do have cases where we do tonsillectomy because we know that that's the source of your IgAs that causes a nephropathy.
So definitely in sleep apnea. So Patrick, yes, in
Sleep apnea, if you have obstructive sleep apnea, it has changed a lot of from good quality sleep, blood pressure control, good performance. Obstructive sleep apnea, if we have proven that this is obstructive sleep apnea that we cannot control with pharmacological medication, that we cannot control with CPAP, we go for tonsillectomy, and it changes. It's amazing.
All right. So then I've got our last question from the evening. Letabo wants to know, what is your favorite calcium channel blocker?
I have what I have access to. I only have access to amlodipine, unfortunately, both here and in Canada where I trained as well. We, like, except for the IV forms in severe cases, but the most commonly used is amlodipine. Nifedipine in acute cases, yes. For hypertensive emergencies, I do not mind, and I do advocate for nifedipine in pediatric. Studies have shown that it doesn't cause huge excursions in terms of your drop in the blood pressures. It's safe to use in pediatrics. So my favorite is what I use commonly, which is amlodipine. But in emergency cases, I would go for nifedipine.
Definitely. I saw you had an app. What app is that you're using? In case anyone wants to use the app.
It's called PetNef. Not PetNef, PetBP. I would share it. Maybe you can share it with the audience via email. So this app, when it was developed, it's based on your percentiles. From the paper that I was, my presentation was based on the 2017 AAP guidelines. And I'm proud to say I beta tested the app when the guys that developed it. Then I tested it in actual kids to check if it was correlating with manual plotting, and it's quite accurate. In most cases, it would say it's not available in your region, and I'm working on that so that it's available throughout, even in South Africa.
Definitely.
I can use it because when I downloaded it, I was still in North America, so I can use it. But it's relevant even for us because the population that was used to create those percentile, the updated percentile, included the African American population, which is relevant to our population.
No, definitely. That would be amazing. Oh yes, Nasbi. Yeah, definitely about the energy drinks, which we have already discussed at length. So Doc, I actually want to thank you for coming through tonight. For a first timer, you did absolutely amazing.
Thank you. Thank you.
No technical glitches, no technical difficulties, and such amazing content, which I know, especially for myself and maybe a lot of us, this was actually quite not just a good refresher for us, but very informative as to what to look for, how to identify, and just how to follow up the pediatric patients that walk through our doors. So I just want to say from us at Clinix, thank you for such an amazing presentation tonight. And definitely we're going to follow up with you next year for hypertensive emergencies. So I just want to say good night and thank you to our entire guests and everyone from the internet for joining us tonight. Thank you and goodbye.